substance use disorder, and we want to make sure treatment and to ensure that all this treatment includes counseling and drug screens. So that is the main purpose of the regulations. More specifically, OFLAC is assigned the oversight authority to do on-site inspections, and there are several operational requirements that are minimum standard requirements for the office-based medication-assisted treatment programs. All right, what is an office-based medication-assisted treatment program? Well, any physician, clinic, or practice in West Virginia that prescribes a buprenorphine product is required to be registered as an office-based medication-assisted treatment program. This includes a lot of different settings, including hospitals, behavioral health centers, individual doctors' offices, larger practices. Now, there are a few exemptions that are listed in the statute and rule, and you can read more specifically about those in the statute or rule, but some of those include the Department of Veteran Affairs, if they run a program, or Indian Health Services, another department of the U.S. government, and certain crisis stabilization units may also be exempt. Again, OFLAC has the oversight authority for office-based medication-assisted treatment programs. So what exactly does that mean? That means that OFLAC receives and processes new and renewal applications, as well as conducting on-site visits to ensure compliance with the statute and the regulations. We also investigate any complaints that may be received regarding a medication-assisted treatment program. So let's talk a little bit about the application and the inspections and how that works. Okay, so first of all, I know Jim said there's some technical assistance screens available in the back, on the back of the presentation, but if you have a piece of paper and pencil, you might want to jot down this website real quick right now and use it as a resource as you navigate through the OB-MAT process. It's OFLAC, ohflac.wv.gov. When I talk about different forms and applications and things that are available, all of these will be available on our OFLAC website. So an existing program must file an application with OFLAC, and it must be accompanied with the application fee of $250. The application must be fully completed. And when you go to our website and you find the application, which will be under the Office-Based Medication-Assisted Treatment Program, the Rule 69 CSR 12, the first 2 pages of that application provide some instructions. So if you're not sure what to put in a field, or gosh, what are they asking? I've never had to fill out an application like this before. Those guidelines there should assist with filling out that application. Once you submit your application to OFLAC, it will be reviewed for completeness, and that we will send you a letter letting you know what to expect, because an inspection will be following shortly down the road. Once we complete an on-site inspection, we will verify that the clinic is in compliance with all areas of the rule. And once the clinic is found to be in substantial compliance, they will be eligible for registration. There's a registration fee that includes the cost of the initial survey, and once that is paid, the clinic receives their initial registration fee. This is registration, and there is an annual renewal of registration, and that form is available also on our website. It must be submitted 30 days prior to your registration expiring. However, the good news for you guys are that the registration renewal does not include another survey. It just includes you to update your information with us on the renewal application. OFLAC will not be back into your clinic to review anything or to review the requirements unless we receive a complaint regarding your practice. So some things to remember about applications and practices. If you're a physician and you run several different locations, Each location must be licensed separately, regardless of whether it's owned by the same person or the same management company. Each location has to have a separate license or a separate application and a separate registration. The rule lists several, the rule includes several required policies and procedures. This screen is just a brief list of some of those policies and procedures. I want to make sure everyone understands this is not a complete list of the policies and procedures, and I'm not going to obviously read them all to you, but I would like to talk a little bit about the policies and procedures. I've spoken to a lot of you guys out there on the phone and some in person about policies and procedures where, there's lots of different practices that prescribe buprenorphine. Some of you are small doctor's offices, some are larger clinics. Several individuals and practices have never had regulatory oversight before. So this has been something that's been a little new, and sometimes something new can be a little scary or even intimidating. Really, all this is what you currently do deduced to pen and paper. We need to see your policies and procedures that must be within the framework of the legislation, and it needs to be written down on paper and available for the surveyor teams when they enter the facility, as well as the policies and procedures. Your clinic must follow the policies and procedures. Something of interest that you may find, out of all the facilities that OFLAC surveys and licenses and registers, the #1 citation found in a facility is failure for a facility to follow their own policies and procedures. So I want to, just spend just a little bit of time here explaining that, as long as your policies and procedures are within the regulations and you follow those policies and procedures, there's no problem with that. I get a lot of questions about, well, we'd like to have more strict policies about drug screens. We'd like to have more strict policies about this. And that's fine. The law just states the minimum requirements. Practices can certainly be more stringent, but I just want to give you a word of caution that if you are more stringent, make sure that you follow those policies and procedures, and make sure that you review them and update them when things change, because we know things change. Something happens and we realize, oh wow, we need to adjust our policy, or we need to do something a certain way. Remember to go back and to adjust that policy so that you can be in compliance. One of the first things that we're going to do when we come into your facility is to ask you for your policies and procedures. So if you deduce that to writing and have it maybe in a binder or in a folder and ready to give to us, that will cut down on the time we're there, and also cut down on the cost to you for the initial survey. When I've spoken with physicians or office managers, they've said, well, we don't have this, we don't have policies and procedures. And I usually ask a simple question of, well, what do you do if someone fails a drug screen? And everyone I have spoken to is able to quickly tell me what they do. So you do have policies and procedures, and most of you that I've spoken to have very good policies and procedures that are well within the regulations. So I encourage you to take the time to, write these down, get them in place and have them ready, because again, that's going to be the first step of the survey process, is reviewing those policies and procedures. Pretty much the second step, or a first combined step of reviewing the policies and procedures, we're going to need to look at patient records. Many of you have electronic patient records. So that means that when our surveyors come in, they will also need to be able to access your records, whether they're paper or electronic. So they may need access to a computer so that they can review these case records. We're not out there to seize your computers or to mess or to make any edits to your records. We just need to review the records to ensure that your practice meets the minimum requirements established in the statute. If you have any questions or issues with this, I encourage you, you're always welcome to reach out to Jim and Matney. He'll explain, his availability. And you can also reach out to us at OFLAC. In addition to myself, I'd like to also mention James Cooper, commonly Jim Cooper, who is the program manager who is over the office-based medication assisted treatment program directly. So we understand this is something new. We don't want it to be scary. We just want good, safe treatment for individuals diagnosed with substance use disorder. We want to ensure that holistic approach, including counseling and drug screen, are being offered to patients so they can get the care that they need. The law requires certain staff designations. I want to make sure I jump right to the bottom of the screen there and let you know that an individual may fill more than one role. For example, we have several small practices, and if a medical director wants to be the program administrator, that's fine. These don't have to be individual people. This is not necessarily 5 different people that have to be there. Your infection control officer can be a nurse that you have on staff, or can be a physician, but someone has to have that area of the law covered for these staff designations. The counselors, Mr. Matney is going to speak a little bit more about the counselor requirements later, but it's important to note that your practice, if you have counseling on site, that's great. If you do not have counseling on site, that doesn't mean that you cannot participate in this program. It just means that you have to have a referral system, maybe a memorandum of understanding or a contract or some sort of relationship with counselors out there so that your patients can get the counseling they need so that we can have this holistic treatment. All right, so these staff designations, there are certain requirements that are outlined in the law for these staff designations. I believe the law is pretty liberal about allowing different substitutions. The program administrator is basically all of you who have practices out there. I'm sure everyone has a office manager, whether the physician does that himself or they have someone else that does that. The program administrator must be identified. And again, under the education and experience requirements, it lists the different education. You can have a bachelor's degree or 2 years experience, or even 6 years experience in the field of substance abuse, or it can be a program physician. What are some of the duties that a program administrator is responsible for? Basically, they're duties of an office manager. They contribute to the development and implementation of the policies and procedures. They maintain the security of the facility. They ensure that the records and the filing and everything is where it's supposed to be. They ensure that patient rights are protected. They are basically the office manager who oversees the daily operations of the practice. The medical director. All clinics must have a designated medical director. The director has to have a full, active, and unencumbered license to practice medicine in the state of West Virginia. The physician must also meet the requirements under Data 2000, and the link here is provided. If you're a physician who is interested in prescribing buprenorphine, you may want to review those requirements. The physician is basically responsible for all things. The medical director is basically responsible for all things that a medical director would normally be responsible for. They are responsible for the overall medical practice. They are responsible for any medical aspects. They are responsible for ensuring that all staff meet the requirements. They're responsible for ensuring that all their records are kept according to the law and the rule. So I don't believe that this is anything different for those of you in small offices or even large offices. As the physician in charge, you're responsible for the overall medical aspects of your program. Other professional medical staff pretty much must be, basically must be actively licensed in West Virginia and have at least 1 year experience in substance use disorder, or be actively enrolled in a plan of education to obtain that 1 year of experience in substance use disorder. Of all the folks that I've talked to out there, I've pretty much not met anyone yet who didn't either meet this requirement or weren't actively enrolled. So I think that this is, you know, pretty basic requirement, and I know all of you guys have at least your professional medical staff are either working towards this or already have this requirement. Something to remember about the hours of operation. During all hours of operation, there must be a licensed program physician on call and available. So anytime that the clinic is open for medical treatment, there must be an active licensed physician on call and available. That doesn't mean that the physician has to be in the practice, but they have to be on call and available. However, when patients are being medically treated, every OB/MAC clinic must have present and on duty at least one of the following. And it can be a physician extender, or a registered nurse. If it is a registered nurse or a physician assistant, then we look back to the point above it that there must be a physician at least on call in case there's an emergency and a physician is needed. All right, with that being said, I'm going to turn it over to Mr. Matney to talk about some of his responsibilities. I do want to say again, at the end of the screen, there are some links to the OFLAC website, and I encourage you all to take a good look at those. There's some forms out there that are available for your use, and hopefully you'll find them helpful. And if you do have any questions, please know that you are welcome to give OFLAC a call, and we'll be happy to work with you and speak with you and work together through this process. So thank you guys, and I hope you have a great day.
Thank you, JoLynn. Just to remind you, I hope you're writing down your questions, because 20 minutes or maybe 15 minutes before the presentation's over, we're going to be taking questions. So write down your questions, and we may not get to all the questions, but we will get to the top questions, and then you'll have my contact information for any additional questions. You'll also have my email address, so you can contact me at your convenience. As I told you at the start of the presentation, I'm the designated state opioid treatment authority. Every state has a state opioid treatment authority that's assigned to that state by the Center for Substance Abuse Treatment. The governor recognizes this person to exercise and take responsibility and authority for substance use disorders in the state and how they're managed, including the treatment of opioid addiction with opioid drugs. In West Virginia, the designated organization that is the State Opioid Treatment Authority is the Bureau of Behavioral Health and Health Facilities, and I'm the designated assigned person to those duties. My responsibilities include reviewing, monitoring, and improving applicable practice guidelines or alternative treatments as they become available. As we know, this is an advancing field, and so there's a lot of research and study that's going on right now with medications and how they can help people with addictive disease. So as they become available, it's part of my responsibility to make sure that you're aware of those medications and treatment procedures, and to provide some technical assistance that will help you implement. Part of my responsibilities also is to ensure that practices are in conformance with any nationally recognized guidelines approved by the Secretary, and to provide technical assistance to ensure conformity with national practice guidelines and best practices. So essentially, I'm the link between you and the Center for Substance Abuse Treatment, which is responsible for the waiver process for your physicians. And so I get all kinds of information about conferences, training availability. I get guidelines from SAMHSA on how to, what are the best practices for the use of these medications, and so forth and so on. So as I get these things, I'll be sure to pass them along to you. What I'm going to ask you to do today, near the end of the presentation, is to email me to give me your email address. So we'll have a complete list of folks that are on the webinar today. So when opportunities become available for additional training, we'll be able to contact you as a group to notify you. The other responsibility for the State Opioid Treatment Authority is to collect any statistical reporting that's required by the federal government or the state government. In this particular rule, there are some statistical reporting guidelines, and they are as follows. You must file a quarterly statistical report with the SOTA, myself, on a prescribed form. And I do have a form that you can use for that. So again, if you send me your email address, I will send you that form. The reporting requirements are very minimal and won't take a whole lot of your time. What we want to know is we want to know the total number of patients that are receiving services at your site. We also want to know the number of patients that are in state, and we want to know how many patients are coming from out of state. As you know, we border, I think it's 5 states. And so often what we know is that people will come over state lines to access services in West Virginia. We want to know how much that's happening. We also want to know the number of patients discharged from the program and the reason for the discharge. We want to know if they were terminated or disqualification for not complying with the program. We want to know if they voluntarily withdrew from the program. And we also want to know if they just dropped out of treatment for an unexplained reason. So this reporting is fairly minimal, and you will send these reports to me on a quarterly basis. And again, if I have your email address, I'll prompt you to do those reports on a regular basis. This reporting, by the way, does go to the state legislature. It goes to the Health and Human Services Legislative Committee, who was involved in the writing of this legislation. I wanted to talk a little bit about counseling staff because I know a lot of medical practices and particularly some of the smaller medical practices don't have on-site behavioral health counseling. So I wanted to talk about that a little bit. This is not anything you really need to be anxious about, because the counseling requirement in this rule can be done on-site, or it can be done by referral. So you can enter into a relationship with a behavioral health entity in your community, or you can even enter into another relationship with another OB MAT who has counseling on site if it's approved by your medical director. And the counseling staff must have one of the following qualifications. They must be a licensed psychiatrist or certified as an alcohol and drug counselor, or they could be have a certification as an advanced drug and alcohol counselor. A counselor, psychologist, marriage and family therapist, or social worker could also do these counseling services. And under the direct supervision of an advanced drug and alcohol counselor, a bachelor's degree can provide these services, except for Medicaid, which I'll explain to you in just a moment. Or these services can be provided by a counselor with a graduate degree actively involved toward working toward licensure or certification, but they must be under the supervision of a licensed or certified professional advanced drug and alcohol counselor. Now, I want to specify something. In West Virginia, buprenorphine is covered by our Medicaid program here in West Virginia. So if you have patients that have a medical card, you must take their medical card in order to pay for their counseling services and their buprenorphine. The counseling guidelines for Medicaid are higher than this rule. According to the Medicaid standard, the counseling must be completed by a master's degree person, and so they don't have to have an active license, but they do have to have a master's degree. If you have someone who is licensed, that's certainly okay. Medicaid will cover LICSWs, licensed psychologists, and LPCs if you have them in your practice as well. If you are referring your patients to another site, you become responsible as the person who is offering these services to make sure that those counseling services are rendered by the site that you're referring the person to, and that the person that is providing those counseling services are under the proper supervision and clinical training in order to provide those services. The supervision requirement for these folks is there has to be 1 hour supervision per 20 hours of service, and the program administrator is responsible for documentation of that supervision. That's not very difficult to do. That's just a notation on when the supervision is happening. Generally, supervision is done in a group format. It can be done individually. It could be done in a combination of group, or it can be done individually. So that's up to you, up to your practice. Any unlicensed or uncertified counseling staff, whether on-site or by referral, must be a licensed or certified professional or advanced alcohol and drug counselor, except if they are Medicaid. If they're Medicaid, it can just be a master's degree person. So I hope that's clear. If you need any further clarification for that, you can contact me directly. Relevant to the fact that you may prescribe the counseling to happen on site or by referral, if you refer your clients for counseling at another location, you have to have a coordination of care agreement. This coordination of care agreement can be accessed on the OFLAC website. So you can go there and take a look at that and see what that's involved. The other condition that you have to have a coordination of care agreement is if you refer a patient for some unusual circumstance to another OB MAT for some reason. Perhaps they have different services than you have or different staffing, and you want the person to go there to consult with a professional. You have to have a coordination of care agreement. And that's really very important because we want to make sure that these patients, that everybody that's involved with these patients knows what's going on with their cases and that their care is well coordinated. I want to talk a little bit about the training requirements for your counselors and other non-physician staff that really do not have the experience in recovery-based OB MAT program. And so this is just a list of the training requirements in this rule. There has to be 20 hours of training requirements. And at first glance, that seems to seem like a lot. But let me remind you that this can be done by webinar, it can be online training, and it can be on-the-job training. So if you have a staff member that the other new staff member can follow around and be mentored, that is considered on-the-job training. Some of these trainings, though, are very, very specific, like cultural sensitivity. So you can find cultural sensitivity online training, so that should be fairly easy to complete. Confrontation, de-escalation, anger management is a specific type of training, so you probably want to look for that. And if you have trouble finding any of these trainings, give me a call or email me, and I'll help you find the locations of some of these trainings. We have organizations in the state that are doing all of these trainings already, so perhaps we could work something out that you could access some of those training sites that are already available. Initial assessment. The initial assessment is when the person comes to your program requesting services. The first step in the process is that they have to have an assessment by the medical director, program physician, or a supervised physician extender. That initial assessment will focus on their eligibility for the program. They really should have a diagnosis of a substance use disorder. And there are other indicators that you'll probably want to do. Perhaps you'll want to do a drug test or right up front. That's up to you. The admission determines basically if the person is appropriate for your services. They do have a substantiated substance use disorder and meet accepted medical criteria. For a full list of the documentation to be required in the initial assessment, refer to Code 6912-20. There are some high-risk groups that are specified in this rule that it's not necessary to highly substantiate that they have a positive drug test or objective symptoms of a substance use disorder. And that's because these high-risk groups, are groups that are written into federal legislation that really do get priority on a national and state level for services. The first one here is the pregnant woman. We know in West Virginia that we have a high infancy exposure rate, particularly for opioids in our state. So you're going to come in contact with these women. And so for a pregnant woman who is coming and requesting these services, it's not really necessary that the medical director or the physician really substantiate real in detail what objective symptoms are. The other person is a prisoner who's just recently released from a correctional facility in the West the last 6 months. So if they come to you requesting services, they don't have a positive drug screen because they've been in prison or another correctional setting, that does not exclude them. That's not an exclusionary criteria for them to access services with you. It could be a patient who is a former patient who successfully completed treatment, but comes back to you maybe days, weeks, or months later saying that they're at imminent risk of relapse. You can go ahead and admit that person immediately back into your program based on those facts. An HIV infected patient with a history of intravenous drug use. A patient who has been deemed as a high risk by the medical director or treating physician. So you can see there's a lot of leeway here that this rule does give medical directors and treating physicians to admit people who are in these high-risk groups without clear substantiated objective symptoms or even a positive drug screen. There's some post-admission assessments that occur after the person receives that initial assessment and are admitted formally to your program. There are some things that have to happen after that fact. The OB-MAT program will develop and implement patient protocols. That's how are you going to treat your patients? What is the treatment regimen for them? There needs to be treatment plans or treatment strategies that are clearly outlined in your policies and procedures. And there needs to be profiles for treatment of patients seeking medication-assisted treatment. Listed below are some of the post-admission assessment criteria. There has to be, of course, a history and physical. There has to be a mental health exam. A diagnosis of a substance use disorder or other diagnosable conditions needs to be documented in the file. This rule does require that you do toxicology tests for drugs, alcohol, hepatitis B, and hepatitis C screens. Although HIV is not a required test in this legislation, I feel it's probably best practice to do that screening as well. Pregnancy tests should be done for women of childbearing ages. And the coordination of care agreement, which I've already mentioned, needs to be in place for patients who are referred off-site for counseling requirements or other services. And there needs to be documentation of inquiry into the controlled substance monitoring database. That's very, very important, because there is a requirement in this rule that you document in some way that there has been an inquiry to the fact of whether these patients are accessing services at another OB-MAT or another program for medication-assisted treatment. Certainly, we don't want patients going to different providers that are unknowledgeable of each other receiving services. So the controlled substance monitoring program will help you with that. There's also an inquiry, as I said, that a patient is being treated at another MAT program. Patient record guidelines. All patient records should be kept confidential. And for you folks in medical practices that aren't used to working in the substance use field, I really encourage you to read and review the federal confidentiality statutes. I can provide a copy of that. That's called CFR 42 Part 2. And they're fairly stringent, and they're different than HIPAA regulations. So, and they recently were changed and updated and revised by SAMHSA. So it's really very critical that you read those confidentiality guidelines in regard to your patients. And again, I can provide you a copy of that. Your records need to be updated in a timely manner. As we all know who have worked in the behavioral health and the medical field, if it's not documented in your record, essentially it didn't happen. This is critical. Information may be entered by the designated program staff, and it must be approved by the program physician or physician extender. That doesn't mean they have to sign off on your particular entries into the medical director in the medical record, but it doesn't mean that they need to supervise what's going into the medical record. And of course, your entries must be legible, organized, and there has to be a way for that allows records to be retrieved. So that last one is a difficult one. Getting people to write legible and be organized sometimes is a challenge. So it's a constant challenge for most of us. Prescriptions and dosage. This legislation doesn't prescribe particular doses. That's really left up to the treating physician and the medical director. Neither does it say how long that the patient can be kept on these medications. That is up to the discretion of the medical provider. What this legislation wants to make sure of is that the patient is getting the correct doses of medication that will reduce their abstinence syndrome, any drug cravings, and that it blocks the effects of illicitly acquired opioids without really inducing any undesirable effects. So we want to make sure that the person is getting the optimal dose in order to reduce cravings and really make the person more comfortable in order to really work a program of recovery, develop a recovery plan, work with their counselor without being distracted from drug cravings. Prescriptions, this rule talks about things that need to be on the prescription form. They're pretty routine for you folks. I don't think this is anything new to you, but it does require that you have your regular DEA number and that you have your Data 2000 ID number on the prescription. Drug screens. Drug screens should be done monthly for all of your patients. And there should be at least one random drug screen quarterly during the course of treatment. And although this rule doesn't say that drug screens should need to be observed or required to be observed, it really is best practice with these patients that you have a procedure and a policy for observed drug screening and testing. The results of the screening need to be recorded, of course, in the medical record. And as a result of the drug screening, there needs to be some follow-up, perhaps some therapeutic action in case the person screens for other substances other than the medication they're supposed to be taking. There has to be a policy and procedure for intensifying the treatment in some way in a graduated fashion. I really want to caution folks clinically that because a patient does test positive for another substance when you do these drug screenings, that doesn't necessarily mean that you need to discharge the patient immediately in a punitive way. What you should do and what is best practice is that you should have a conversation with the patient about the fact that they did test positive, what that means for their program, and then what are your therapeutic requirements for them? Are you going to increase their counseling, their monitoring? Are you going to increase their drug screening? That's up to you as a program. And in a few weeks, we're going to be doing another webinar that will kind of help you with those graduated increases in therapy for patients who are not complying completely with the program. So that will help, and I think we can give you some good guidelines. There's some really great programs in West Virginia that are already doing this work and having a great deal of success. So the full information on laboratory services and drug screens, you can go to West Virginia Code 6912-31. Multiple program enrollments. As I've already mentioned, we don't want patients who are enrolled in multiple programs. So there has to be a good faith attempt on your part in order to make sure that doesn't happen. Again, the PDMP, the prescription database monitoring system, is a good way to do that. You can make this part of your interviewing process with the patient. And so as long as you make a good faith attempt in order to do that, you should be fine. These are the helpful OFLAC links that Joanne mentioned earlier. Again, you don't have to sit and write these down at this point. We'll make this PowerPoint available to you. We'll post it on the website so that you can go back and access this, or I can email this PowerPoint to you. Also, I've pulled some treatment resources that are very good from SAMHSA. Some medication-assisted treatment guidelines, some guidelines for the use of buprenorphine and the treatment of opioid disorders, and then some facts about buprenorphine. Just a kind of little booklet that you can give patients when you start them with this treatment. And then for technical assistance, I've given you my information here and my phone number and my email address. So I'll leave this on this slide for right now so that you can copy that information down. But what I want to do right now is entertain any pressing questions that you have for the next few minutes and see if we can answer those questions for you. Again, if we don't get to all the questions, you can contact me directly and we will get an answer for you. You got questions for me?
Yeah, a few.
Okay.
Brian said that I have my unannounced survey in February. No news from OFLAC so far. Brian mostly, he hasn't heard from him so far.
Okay. And his question is, what is the timeline for?
Yeah, but I guess what is
Okay, Brian asked a question. He had his survey in February, and he's wondering what the timeline will be for him to hear back from OFLAC.
Hi, Brian. This is Jo Lynn. I am sorry that you haven't received your statement of deficiencies or some information from OFLAC yet. We are working hard to try to be compliant with our requirements. The rule was in the legislative process at that time and going through some other changes. So as you can imagine, we are a little overwhelmed in our office also. So we are working hard, and I will check to see that we get any reports out to you that are outstanding so that you can get your registration and get that moving. We have received, just to kind of let you guys know, thus far we've received 99 applications for office-based medication-assisted treatment programs. We have been on site at 10 clinics. 4 clinics are in the final stage process of being registered. We're just waiting on the final step, which includes the payment, and then they will be registered. It is, as it's something new for you guys, it is also something new for us. So we have to get our staff trained and ready to go. And the program that is responsible for the OB-MAT clinics, they also do behavioral health centers, ICFs, the opioid treatment programs, and pain clinics. And I'm not making excuses. We'll get that to you. It is moving slower on our end, getting those results out to you than what we would hope. But we plan on getting that moving faster for you. So please be patient with us also.
Thank you.
Thanks, Brian.
I think
Thanks.
Chelsea Gunther has the same question. She says they said that we would have a report within 10 days. Was that following the same?
Yes.
Yeah.
So I apologize, Chelsea.
Can you identify where the coordination of care agreement form is located on the OFLAC site? Search the site but cannot locate the form.
That is very good. I had the coordination of care agreement and some of the other forms will be on the OFLAC website within the next week. So not all the forms have not all been updated. We wanted to finalize them and tweak them so we wouldn't have to take them down and put them back and all that good stuff. But we will get those forms out on the website next week. And when you send Jim Matney your email information, I will make sure that he sends updates and lets you know, hey, OFLAC's website's updated. These forms are out there.
We're told to print the Board of Pharmacy report at each visit and place in the chart. Can we view and note that instead?
Not every visit. I believe there are some specific requirements in the rule of when that Board of Pharmacy report must be accessed. It's not necessarily every visit, and it's in the statute.
So we can answer that and get back to
Yeah, we can answer the
Okay.
specifics and get back with you, but it is not every visit, but it is a requirement in the statute.
Where do we find acceptable risk stratification tools?
I'm going to let Mr. Matney help with that.
Acceptable risk
Stratification is what it says.
Is it in the rule? It's SAMHSA? You can find that on the SAMHSA website, I'm told. And if you want to email me, I'll make sure that you get that information. I'm very familiar with the SAMHSA website. I don't know particularly about that section, but I'll find it for you and email it to you.
Can you go over the CSMP database?
That's the Board of Pharmacy, PDMP. And so I can find some information about the PDMP and connect you with the Board of Pharmacy if you need some information on how to access that database. But I don't know the specifics of it because we don't do that here. All docs should have logins for the PDMP. It's part of the regular process. So that should already be a part of your availability there. But I, again, can get you some information on that if you want to send me an email.
Is there a checklist that we can go to get to prepare for inspection? How do we know what needs to be done in layman's terms?
Okay.
Are there specific recommended courses for staff training?
All right, I can speak to a checklist. There is not per se a checklist. However, if you go to our website and you review the survey protocols, it's going to explain to you what happens during a survey process. Basically, the checklist are the statute and the legislative rule. The survey protocols will walk you through, the surveyors enter the building, they, what they're looking for, what they're going to review, and that'll give you an idea of how the process works. As for the training, I believe Jim spoke to that earlier, that he may have some resources.
This particular rule doesn't say how many hours of each training. It just says 20 hours in the first 6 months. So, cultural sensitivity may be an hour. So there's no specified. It just has to be done and it has to be documented. So if you want some more information on what a particular course would look like, I can get that information for you, because those courses are already being provided by our comprehensive providers. So I'm sure I can get my hands on that.
When is the first quarterly report?
First quarterly report would be due, that's a good question. I'm thinking after they become licensed, register. After you become registered, then you would be responsible for the next quarterly report. So quarterly reports go, like the first quarterly report contains data from January to March, and then the quarterly report is due in April. But if you don't get registered until March, obviously there's not a whole lot you can do about that first quarterly report. So your responsibility would be to send the second quarterly report, because then you would have been operational during that time.
Is the CSMP the same as the BOP? Not, how do we access it?
It's the same thing. A BOP is the Board of Pharmacy. You'll hear CSMP too, but it all means the same. CSMP and the PDMP are the same thing.
You verify that a client is not enrolled in another MAT. Does the Board of Pharmacy report about this, or suffice? For this, or do we need to develop a consent for checking within a certain mile radius of the OPPs as well?
What I would do is I would develop a form and have the patient sign it, where they certify that they're not enrolled in another program, and have the patient sign that. And then you can have the backup of the PDMP as well. So with those two things, I think you'll be fine.
Remember, methadone is not listed on the Board of Pharmacy report. So I wanted to keep that in mind. There are no regulations in the OB-MAT regulations regarding checking for certain mileage or anything like that. So you need to just come up with your own plan to ensure patient safety, that you've checked those things and that you feel comfortable with.
The post-admission assessment would also be conducted by the physician, correct?
It would be the physician or the physician extender or the medical director.
I am getting faxes from other OB MATs asking if their patients are enrolled here. Is that appropriate?
Well, I mean, there's some confidentiality guidelines here. I mean, obviously, you're not going to be able to give out that information unless the patient signs a consent for you to do that. And then this goes back to CFR 42 that governs federal confidentiality statutes. And that's why I really stress that, because the specific guidelines for those confidentiality statutes nationally are very stringent. So Again, if you email me, I can send you a copy of those for your review. So, but basically, you've got to get the patient's permission in order to release substance abuse information.
Okay, how can we tell if a patient is enrolled in OB/MAPs? It's time consuming and dicey to call others and ask. Is there a better way?
This rule doesn't require you to call and ask. It requires it to be part of your assessment with the patient, that you ask them, that you get them to sign the certifying that they're not involved, and that you check the PDMP, and that should satisfy this requirement.
Part of your diversionary control plan, as well as your drug screens, can assist with that.
That's not what the reviewers told us in FMRS.
I'm sorry.
What'd you say, Chelsea?
The reviewers that came to FMRS told us that we had to have like 100-mile radius check, and it was something that we would send out to other facilities.
Well, at that time that your survey was done, it was in February, I believe. And that was part of the legislative rule at the time. But through the legislative session, there were some changes made to the rule. So
Okay.
that would no longer be a requirement.
Okay, thank you for that clarification.
No problem, Chelsea.
If you have a non-compliant pregnant patient, what are the guidelines that you follow?
Matt?
Non-compliant pregnant patient.
If you have a non-compliant pregnant patient, it's part of your responsibility. If you're not going to treat that patient and you feel that they need to be discharged for non-compliance, to make sure that they get connected to another provider the best way that you can. You can set up an appointment with them, make sure they have a referral in hand, and so that you properly cover yourself and use best practice to getting that individual to another provider. We're going to have to end the questions right now because we're a little bit over time. But I wanted to end by letting you know how you're going to get your certificate of completion for the training today. What I need for each of you to do is to send me an email. When you send me an email, I'll send you back an evaluation form, because in order to do CEUs, we have to have evaluations in hand. So I'll send you an evaluation form, and when you complete the evaluation and send that back to me, I will then forward you your training certificate via email. So if you don't need a training certificate, if you're not interested in that, I would still like you to email me so that I can keep your email and your contact information on hand. So when we do further trainings like this, and when I get information that I think impacts what you do, I'll be able to forward that to you. But we want to take this time to really thank you for joining us today, and we wish you much success in your program. And if we can help in any way, please do not hesitate to reach out to us. Thanks so much, and have a good day and a good weekend.
Thank you all. I hope they know.